Hi, I'm Jamie Von Rohn from the Supportive Oncology Conference, which has been very exciting. And I have with me 3 physicians from our discussions this morning: Jean Holly, a nephrologist; Brad Stewart, an internal medicine palliative care specialist; cardiology expert in end of life. I don't know what to call you, Coy.
That's good.
And Paul Glare, who works at Memorial Sloan Kettering in the Cancer and Palliative Care Interface. We had some really exciting discussions that left us with questions, and a discussion that I think could have gone on for hours about the next steps in communicating not only what we do, but what are the appropriate ways to explain this and the needs of patients.
Yeah, I think all of us, we all brought our data and presented it, which is exciting because there's new data now that really is pretty compelling, that we know more about prognosis than we did just a few years ago. We know how important communication is. But most of all, where we went at the end was how important it is to get the shared decision-making process really going with patients and families, and maybe some of the ways to start doing that as physicians, and also using maybe teams of people who we can pass the ball off to.
Yeah, I agree. And actually, after the session, a physician came up to me and told me that he'd been diagnosed with a malignancy many years ago, and he was still working and here today. And so I think the important point with communicating prognosis is that while we're getting better at working out median survivals and risk factors, that, as Stephen J. Gould said, the median isn't the message. And we know more that these are exponential curves and we can make predictions, and we shouldn't be saying you've got a month to live or 6 months to live, but most people like you might have 6 months to live, but for the individual it could be a very big range that could be from a few days to many years, even though the median is this. And I think a more nuanced communication is important, and we need to better understand the data we have to go into it to improve that kind of communicating.
Right, and I think we also spoke near the end of the session about how societal and policymaker impetus into prognostication, and how, in addition, how we communicate with them in order to make our patients better educated to learn about these issues, no matter what chronic illness or actually society in general without illness. How do we get patients and families to participate in the process of thinking about prognosis and about planning for the ends of life?
Right. Right.
Yeah, life has 100% mortality, and we don't talk about that.
That's right.
Yeah, the interesting thing to me is that we do have data that shows that people, patients and their families, all actually want to know kind of what's coming. It's very hard for us as physicians, particularly with people we know well and we've worked with for a long time. We have a lot vested in our patients, and we like it when they stay well. But when it's apparent to us that that's not the way things are going, people actually want to know that. It's very clear now in the data. And not only that, when we tell them and share with them honestly, not only is there not depression or anxiety, people actually benefit from it and find it easier to make decisions that turn out to be very sensible and, by the way, less costly. And we didn't get into cost today, but it's a huge topic, certainly in Washington and in all medical centers that I'm aware of right now. And within the next few years, it's going to get even more acute. We have to find ways to do what people want to avoid becoming patients, especially in the hospital. And there really are ways to begin to focus on doing that.
Yeah, that's true, but I think there's still a lot of challenges there, and I think the systematic reviews about communication of prognosis raise issues like, you know, the ambivalence that people have. They want to know it, but they don't want to know it. Today they might want to know it, tomorrow they don't want to know it. They want some more certainty, but they don't want their hope taken away. And and providing information that's in a suitable format, whether it's words or figures or tables or graphs or whatever, are big challenges. And so the communicating piece of it's very tricky. And also people get their information from lots of different sources, lots of other healthcare professionals, family, friends, person over the back fence, the internet. So I think giving this information is very, very challenging. But at least I guess we understand what the barriers are and what the challenges are, and we can start gradually working on them.
I'm always concerned that we talk about this as a transition in care, when in fact this should be a process throughout our whole relationship. That the advanced care discussion should occur when we meet someone, and we should say, gee, I have an advanced directive, you should too. This is just about being an adult in society and preparing, and that this is a fluid document. And someone raised that question from the audience, and I think it's key that we keep talking about it as something natural in the same way we talk about planning for a child's wedding. It's a process.
Right.
Yeah.
And the end result isn't a goal of a piece of paper. It's to encourage families and patients to talk to their families, and then let us in on the conversation too, so we can all achieve the goals. What is the overall goal that we have for the rest of our life?
Yeah, I've been a physician now for a third of a century, which astonishes me. But I've gone from being an acute care general internist. I did a lot of work in the ICU, and then I went over to end-of-life care and sort of left that behind. And now I find myself right back in the middle of it, because I've realized, along with a lot of other people, that we have a big problem in this country, a big fracture, fragmentation between who's treatable and who's terminal, who can be cured or treated, and who needs comfort care. And I think you hit a very important point, is that we don't have, and the hospice benefit and regulations have worsened this, we don't have a real continuum of care. There's a Grand Canyon of unmet need between the people who look treatable and the people who look terminal. When you're terminal in the hospital, you must get out. And I think closing that gap is where a lot of innovative programs are going, and there's a lot of interest nationally in new models that make that whole continuum really continuous. And I think that's where we need to go.
And I think that's where the future is integrating palliative care principles throughout the course. And that's what this meeting is about. Thank you.